Encephalitis. S. Sears, MD. Herpes simplex virus type 1. Most common cause of fatal sporadic encephalitis. HSV infection of the CNS. Immediate CNS invasion from the trigeminal nerve or olfactory tract. Follows an episode of primary HSV1 of the oropharynx. CNS invasion after recurrent HSV1 infection. Represents viral reactivation with subsequent spread. CNS infection without primary or recurrent HSV1 infection. Represents reactivation of latent HSV in situ within the CNS. Pathogenesis necrosis occurs in the temporal lobe. Direct viral mediated inflammation. Extent of viral load may be directly related to severity of disease. Indirect immune mediated CNS damage. Not more common in immunocompromised patients. Clinical features: focal neurologic findings are acute, less than 1 week. Altered mentation, level of consciousness. Focal cranial nerve deficits. Hemiparesis. Dysphagia. Aphasia. Ataxia. Focal seizures. Fever. Later in the clinical course. Diminished comprehension. Paraphasic, word substitution, spontaneous speech. Impaired memory. Loss of emotional control. Behavioral syndromes: hypomania, Kluver-Bucy syndrome, states of amnesia. Inflammation of the temporal, limbic system. Elevated mood. Excessive animation. Decreased need for sleep. Inflated self-esteem. Hypersexuality. Kluver-Bucy syndrome. Psychic blindness. Loss of normal anger and fear responses. Inappropriately oral and sexual. States of amnesia. Recurrent brainstem encephalitis. Upward gaze. Facial numbness. Signs of involvement. Corticospinal tract. Spinothalamic tract. Cerebellar pathways. Investigations: laboratory electroencephalogram, EEG, CSF nonspecific. Lymphocytic pleocytosis. Increased RBC. Elevated protein. Normal glucose. PCR diagnostic confirmation. Electroencephalogram, EEG. Nonspecific. Continuous periodic lateralizing epileptiform discharges. Investigations: imaging, CT, MRI. Predominantly unilateral temporal lobe lesions. May be associated with mass effect. MRI. More specific than CT. Brain perfusion studies demonstrate hyperperfusion early in disease. HSV encephalitis. Differential diagnosis. Arthropod viruses. Other herpes viruses: CMV, EBV, VZV. Viral meningitis. Brain abscess. Post-infectious race syndrome. Acute disseminated encephalomyelitis. Vasculitis. Neurosyphilis. Primary or secondary malignancy. Toxic encephalopathy. Diagnosis: gold standard if PCR negative. Detects HSV DNA in the CSF. Positive early in the course of the disease. Detectable 2 to 4 weeks after the onset of illness. If PCR negative, patient clinically deteriorates on therapy. Brain biopsy. Still the only accurate way for certain diagnosis. CSF antigen and antibody determinations not helpful. Viral culture rarely positive. Treatment: acyclovir 10 mg/kg/4q8 DRS for 21 days. Infuse slowly and with fluid to prevent crystalluria and renal failure. Shorter courses have been associated with relapse. Treat early. Before a loss of consciousness. Within 24 hours onset symptoms. Glasgow Coma Scale 9 to 15. Discontinue therapy. Low probability of encephalitis. Normal imaging, CSF, mental status. Negative CSF PCR. Continue therapy. High risk patient. Abnormal imaging, CSF, mental status, seizures, abnormal EEG. Look for alternative Y-PCR negative. Early testing, antiviral therapy, PCR inhibitors, bloody CSF. Prognosis fatality 70% survivors serious neurologic deficits. Significant neuropsychiatric difficulties. Significant neurobehavioral issues. Rabies neurotropic RNA viruses human infections. Belong to the family Rhabdoviridae. Human infections. From rabid animals through a bite. In developing countries, dogs account for 90% of reported cases. In the United States, 4 major animal reservoirs: bats, raccoons, skunks, foxes. Unusual transmission. Organ donor died of encephalitis, unknown cause. All recipients were diagnosed with rabies. Pathogenesis: viruses deposit in peripheral wounds. Exposed skin versus bite through clothing. Face and head versus peripheral site, distance from CNS. Amount of virus in the saliva. Degree of innervation at the site of bite. Host immunity. Pathogenesis: retrograde passage of virus, viral replication in CNS. Peripheral nerve. Dorsal root ganglia. To brain. Viral replication in CNS. Localizes. Brainstem. Thalamus. Basal ganglia. Spinal cord. Spread from CNS. Heart. Skin. Salivary glands. Clinical manifestations. Classic forms: encephalitic, hydrophobia, aerophobia, pharyngeal spasms, hyperactivity, paralytic, quadriparsis, mimic Guillain-Barré. Cerebral involvement is late in the course. Clinical manifestation: non-classic form, bat-associated rabies, neuropathic pain, sensory/motor deficits, chariform movements of the bitten limb, cranial nerve palsies, myoclonus, seizures. Clinical manifestation: 5 general stages. Incubation period. Prodrome. Acute neurologic syndrome. Coma. Death. General stages of disease. Incubation period: 1 to 3 months. Can be days to 1 year. Prodrome. Last stays not more than a week. Flu-like symptoms: malaise, anorexia, irritability, low-grade fever, sore throat, headache, nausea, vomiting, viral site of entry, paresthesias, pain, pruritus, percussion myedema. General stages of the disease. Acute neurologic syndrome. Lasts 2 to 7 days after prodrome. Encephalitic rabies. Paralytic rabies. Atypical rabies. Coma. Generalized flaccid paralysis. Respiratory failure. Vascular collapse. Death. 2 weeks after the onset of coma. Diagnosis: clinical presentation, investigations, saliva samples. Reverse transcriptase PCR. Viral culture. Neck biopsy. Full thickness. At the hairline. Cutaneous nerve. Follicle. RT/PCR. Immunofluorescence staining for viral antigen. Serum and CSF. Antibody titers. Brain biopsy. Rabies negri body and neuron. Rabies under electron microscope. Treatment: rabies vaccine, human rabies immune globulin ribavirin. Multiple site intradermal injections to accelerate the immune response. Human rabies immune globulin. Total dose 20 IU/kg. Intramuscular. Infiltrated around the wound. To promote clearance of the infection. Ribavirin. Intravenous and intraventricular. IFN alpha. Ketamine. Intravenous infusion. Inhibits rabies virus replication. Vaccine. For patients not previously vaccinated. Prevention: rabies vaccine pre-exposure, post-exposure. Rabies research lab workers. Rabies biologics manufacturing workers. Veterinarians. Animal control workers. Wildlife workers. Post-exposure. Any patient not previously vaccinated. West Nile virus encephalitis. Most widely distributed of all the arboviruses. From the group of flavivirus. Distribution. Now North America. Was from Africa, Middle East, Europe, Russia, South Asia, Australia. Carried by wild birds. Transmitted by the mosquito bite from the Culex species. Transfused blood. Transplanted organs. Culex pipiens northern house mosquito. Clinical manifestation. Incubation ranges from 2 to 14 days. West Nile fever. Fever. Malaise. Back pain. Myalgias. Anorexia. Persists for 3 to 6 days. Most frequent symptom. Maculopapular rash. Involves chest, back, arms. West Nile fever, rash. Neuroinvasive disease. Increased risk. Older age. Alcohol abuse. Diabetes. Immunocompromised. Encephalitis. Most common. Presence with headache, fever, nausea, vomiting. Associated with muscle weakness and flaccid paralysis. Neurologic disease, tremor, myoclonus, Parkinsonian features, rigidity. Postural instability. Bradykinesia. Cranial nerve palsies. Facial weakness. Vertigo. Dysarthria. Dysphagia. Acute flaccid paralysis syndrome. Anterior horn cell process, like polio. Seizures. Cerebellar ataxia. Optic neuritis. Weakness. Brachial plexopathy. Radiculopathy. Demyelinating peripheral neuropathy. Other clinical features. Ocular manifestations. Chorioretinitis. Vitritis. Uveitis. Rhabdomyolysis. Myocarditis. Hepatitis. Pancreatitis. Central diabetes insipidus. Palpable purpura. Diagnosis investigations: LPCSF imaging, CT, increased lymphocytes. Increased protein. Normal glucose. Imaging. CT. Usually normal. MRI. Hypertensity. Leptomeninges. Paraventricular. Basal ganglia. Thalamus. Caudate nuclei. Brainstem. Spinal cord. Diagnosis. Serology. IgM antibody capture enzyme linked immunosorbent assay. Within first 8 days of illness. Convalescent phase serum as well. Viral nucleic acid. CSF. IgM antibody. West Nile fever treatment: supportive prognosis, increased risk. Older age. Immunosuppressed. Long-term sequelae. St. Louis encephalitis, acute mosquito-borne illness. Virus is a single-stranded RNA flaviviridae. Vector Culex mosquito. Second leading cause of encephalitis after West Nile virus. Principally occurring Ohio, Mississippi Valley, Eastern Texas, Florida, Southeastern Canada, Northern Mexico. St. Louis encephalitis, human infection, most severely affected regions. Inoculation of the virus into human host. Spread via lymphatics and blood. Reaches the choroid plexus. Results in lymphocytic encephalitis. Most severely affected regions. Hypothalamus, cerebellum, cerebral cortex, basal ganglia, brainstem, cervical spinal cord. Incubation period 4 to 21 days. Clinical features: prodromal symptoms 4 to 5 days, fever, severe headache, photophobia, nausea, vomiting, malaise, myalgias. Clinical features: neurologic signs, rapid onset, alerted sensorium, tremors, eyelids, tongue, lips, extremities, cranial nerve dysfunction, unilateral facial motor weakness, oculomotor dysfunction, dysarthria, myoclonus, opsoclonus, nystagmus, ataxia. Investigations: laboratory: increased ALT and CPK, hyponatremia, CSF, increased lymphocytes, increased protein, normal glucose, negative gram stain. Imaging: no specific abnormalities. EEG, diffuse slowing. St. Louis encephalitis diagnosis: serum CSF antibodies. Acute and convalescence. Treatment: no specific antiviral therapy. Supportive: interferon alpha 2b. Reduced likelihood after first week in hospital. Quadriplegia, quadriparesis, respiratory insufficiency. Outcome: death in the first 2 weeks, poor prognosis 20%. From direct brain injury. Poor prognosis. Sustained high fever. Convulsions. Advanced stage. Severely depressed state of consciousness. Convalescence. Weeks to months. Residual. Headaches. Irritability. Memory deficits. Persistent tremor. Prevention: no available vaccine. Mosquito control. Dengue virus infection. Member of the family Flaviviridae. Distribution in every continent, except Europe and Antarctica. Transmitted by mosquito Aedes aegypti. Breed in or close to houses. Aedes aegypti mosquito. Clinical presentation: asymptomatic infection. After incubation period 3 to 14 days. Self-limited dengue fever. Dengue hemorrhagic fever with shock. Asymptomatic infection. Seen in children under the age of 15 in endemic areas. Dengue fever, classic acute febrile illness, headache, retroorbital pain. Marked muscle and joint pain. Fever lasts 5 to 7 days. Biphasic. Second febrile phase for 1 to 2 days. Rash in 2 to 5 days after fever. Hemorrhagic manifestations. Spontaneous bleeding. Melena. Purpura. Classic dengue physical exam, laboratory conjunctival injection. Pharyngeal erythema. Lymphadenopathy. Hepatomegaly. Maculopapular rash. Laboratory. Leukopenia. Thrombocytopenia. Serum aspartate transaminase elevated. Virus often found in high concentration in the liver. Dengue hemorrhagic fever. Defined by the World Health Organization. 4 cardinal features. Fever lasting 2 to 7 days. Marked thrombocytopenia, DEC platelets. Increased vascular permeability. Plasma leak syndrome. Preceded by abdominal pain. Hypothermia. Hemoconcentration. Pleural effusion. Ascites. Hemorrhagic tendency. Positive tourniquet test, greater than 20 ppke. Hematemesis. Melena. Epistaxis, positive tourniquet test. Uncommon syndromes: liver failure, encephalopathy, encephalitis, seizures. Motor weakness. Mononeuropathies. Polyneuropathies. Guillain-Barré syndrome. Transverse myelitis. Myocarditis. Cholecystitis. Retinal vasculitis. Diagnosis: provisional diagnosis can be made on clinical basis. Laboratory testing. Acute phase serum plasma for IM immunoassay. If negative, repeat in 6 days. At least 10 to 14 days later, convalescent serum. Both specimens analyzed together. By hemagglutination inhibition. Viral detection. Direct culture. Detection of plasma leakage. Ultrasound. Direct dengue viral culture. Treatment. No specific therapy. Mortality dependent on severity of disease and is variable. Directed at fever, acetaminophen, bleeding, transfusion, red blood cells, platelets, reversal of hypovolemic shock, 4 fluids, prevention of end organ damage, arthropod-borne encephalitis. Similarities. All viruses. Family. Togaviridae, Flaviviridae, Bunyaviridae, Reoviridae. Transmitted to humans via vector. Mosquito culex. Tick. Incubation time after inoculation. From 3 days to 2 weeks, arthropod-borne encephalitis. Similarities. Prodrome. Flu-like illness. Results in encephalitis. Diagnosis. CSF. Lymphocytosis. Increased protein. Normal glucose. Gram stain negative. IM antibody by capture immunoassay in CSF. Demonstrate viral antigen or genome in tissue. Treatment. Supportive. Prevention. Arthropod. Control. Avoidance, family Togaviridae, Eastern equine encephalitis virus. Western equine encephalitis virus. Venezuelan equine encephalitis virus. Eastern equine encephalitis virus. Virus distributed North, Central, South America, and Caribbean. Virus transmitted by mosquito found in swamp areas. Peak incidence in August and September. Outbreaks along the Atlantic and Gulf coasts. Neurologic deterioration is rapid once symptoms begin. Common. Seizures. Focal neurologic signs. Sequelae. Convulsions. Paralysis. Mental retardation. Mortality is 30%. Western equine encephalitis virus. Found in North and South America. Flooding. Increases breeding of Culex mosquito. Summer outbreaks. Large outbreaks. Horses and humans. Western United States. Decreasing incidence. Declining horse population. Equine vaccine. Improved vector control. Neurologic sequelae. Common in infants. Mortality is 3 to 7%. Venezuelan equine encephalitis virus. Distributed from Florida to South America. 6 subtypes. Epizootic subtype IAB and IC. Produces outbreaks of illness in animals. Cause equine and severe human illness. Transmitted by several mosquitoes. Enzootic subtype IDF 2, 3, 4, 5, 6. Infects animals' sporadic illness. Causes illness in humans. Transmitted by Culex mosquito. Long-term sequelae and fatalities uncommon. Family Flaviviridae Japanese encephalitis virus. Murray Valley encephalitis virus. Powassan virus. Tick-borne encephalitis virus. Japanese encephalitis virus. Widespread throughout Asia. Occurs in late summer in temperate regions. Transmitted by Culex mosquito in rice fields. Seizures are common. Extrapyramidal features. Expressionless facies. Hypertonia. Cogwheel rigidity. MRI abnormalities. Thalamus. Basal ganglia. Midbrain. Pons. Medulla. Diagnosis. Viral antigen or DNA in tissue. Mortality is 30%. Severe neurologic sequelae. Motor weakness. Cerebellar signs. Extrapyramidal signs, Murray Valley encephalitis virus. Occurs Australia, New Guinea, eastern part of Indonesia. Transmitted by Culex mosquito. Seizures are common in children. Severe cases. Hyperactive reflexes. Spastic paresis. Coma. Death. CT. Mild hydrocephalus. Cerebral edema. Decrease in thalamus to brainstem. Mortality is 30%. Neurologic sequelae is 50%. Powassan virus found in eastern Canada and northeastern United States. Occurs from June to September. Transmitted by ticks. Species. Ixodes. Dermocenter. Incubation period 8 to 34 days. Presence with GI complaints. Seizures. Confusion. Mortality 5 to 10%. Neurologic sequelae. Hemiplegia. Headaches. Memory impairment. Ophthalmoplegia. Tick-borne encephalitis virus. Subtypes. Far Eastern. Western Europe. Siberian. Transmitted by ticks. Species. Ixodes. Ingestion of raw milk, cows, sheep, goats. Occurs in spring and summer. Gastrointestinal complaints common. Forms. Meningeal. Poliomyelitic. Polyradiculomuritic. Chronic. Over months to years. Parkinson-like, progressive muscle atrophy, mental deterioration. Mortality is 1 to 8%. Vaccines are available in Europe and Canada. Family Bunnyaviridae La Crosse, California, encephalitis virus. Found in central and eastern United States. Occurs July to September. Transmitted by Aedes mosquito. Common in school-age children. Common features. Seizures. Focal neurologic signs. CT. Generalized cerebral edema. Mortality is low. Neurologic sequelae 10%. Focal neurologic. Cognitive deficit. Behavioral deficit. Family Reoviridae Colorado tick fever virus. Found in western United States and Canada. Transmitted by the wood tick. Occurs from March to September. Beaks April to June. Clinical features. Petechial rash. Increasing fatigue. Virus infects bone marrow. Leukopenia common. Prognosis is favorable.